Well, it's such a pleasure to be here. I really appreciate you giving me the opportunity to come back and give this talk in person. I had to do it remotely last year due to some unfortunate circumstances, which have all resolved now. But I'm really appreciative to be able to be back and with you here in person to do a national update on stewardship activity from the perspective of the CDC. I don't need the slides to do my disclosures because I don't have any, as you might gather from the way I'm dressed. I think we're up now. I'm going to talk mostly about hospital stewardship. I'll say a tiny bit about what's going on in the outpatient and nursing home arenas. I'm not going to say anything about what's going on in the veterinary sector. If you have questions, we can have some discussion about that because there is an awful lot happening across the full spectrum of human healthcare and also on the animal side as well. Here are the objectives that we will try and cover today. For us at CDC, kind of the centerpiece of what we have done with antibiotic stewardship, this was back in 2014, was to frame what we meant when we said that all hospitals needed to have an antibiotic stewardship program. And for us, this was a really important first step because when we met with the CDC director, Tom Frieden, at the time, who said, yes, this is a great idea, we can make a call for every hospital to have a stewardship program, but he said, you have to figure out what that means, and you have to have a way to measure it. So you have to have a framework that could be implemented and was flexible enough to be done in any hospital in the United States. And so that's where we came up with this idea for the core elements of antibiotic stewardship. We reviewed the literature, we met with lots of experts to try to figure out what are the actions and the structures that were in place that really made stewardship programs successful. And we came up with these. They're pretty generic, right? These are kind of core elements of most quality improvement programs. Education, actions, measuring, engagement of leadership. But these have been, I think, very helpful in allowing us to frame what we think an antibiotic stewardship program needs to have and needs to do. But these are old, right? So the core elements were released in 2014, it's 5 years later, and a ton has changed in stewardship, and mostly for the better. There has been a lot of new research on antibiotic stewardship. There's been tremendous growth in measurement and interventions, so we need to update these core elements. And we are in the process right now of doing an update of the CDC core elements for hospital antibiotic stewardship, which we hope to release later this fall. Some of the areas that I think really need a lot of work and attention is the section on measurement. At the time when we wrote this document, there were very few hospitals reporting antibiotic use data to CDC. We didn't have much experience doing risk-adjusted benchmarking of use. That's changed a lot. And there's a lot of new data on interventions, and that's something that I really want to highlight. So if you look at the section on interventions in the core elements document, the first thing that's listed there is this idea of an antibiotic timeout. At the time, we thought this was an easy and straightforward intervention, could be high impact, and so we put that at the top of this list. However, in the meantime, we have been funding studies to really evaluate some of these practices. And we did fund investigators at the University of Maryland and Johns Hopkins to do a randomized control trial of a provider-initiated antibiotic timeout. And so the timeout is very different from the idea of post-prescription review with audit, right, where a stewardship program reviews therapy and gives providers feedback. The timeout is the idea that the treating team itself looks at their own prescribing after a day or two and makes a determination about whether or not the antibiotics are necessary. That is still, I think, a really important thing to do. We always want providers to be reassessing the therapy that they have prescribed, but the question is that an effective stewardship intervention? Is that going to significantly reduce inappropriate antibiotic therapy? And this is the publication of that study, and what it suggests, and this is the result here, is that they said that the timeout showed no difference in antibiotic use before and after implementation. So the overall rate of antibiotic use did not change after the implementation of a provider-initiated timeout, but it did improve inappropriate therapy. There was a reduction in inappropriate antibiotic therapy. So the question becomes, if you're seeking to reduce your rates of antibiotic prescribing, if you think your prescribing rates are too high, If you implement a timeout, you are probably not going to move that needle. And that, I think, is important context for people to understand, because we have talked to folks who are like, hey, we implemented a timeout. Our appropriateness is maybe a little bit better, but we haven't seen a drop in our overall antibiotic use. And it suggests that this is probably alone not going to get you there. So there is data that we need to bring into the core elements to help people understand what they maybe will and won't get from these specific stewardship interventions. That said, let me show you some data on where we stand with the implementation of the hospital core elements. This is data showing the % of U.S. hospitals that report to CDC that they've implemented all 7 of the core elements. We have been tracking this since 2014. The latest data that I have to show you is from 2017. The 2018 data is almost ready. As all of you probably know from having experience and done this, we collect that data for each year in the first quarter of the next year, right? So we collected the 2018 data in the first quarter of 2019. So that's just recently come back to us at CDC, and we're in the process of analyzing it. But between 2014 and 2017, this 4-year period, we've seen an almost doubling in the number of hospitals that report that they have implemented all 7 of the core elements, from 41% to 76%. So that's a pretty encouraging rise, and I suspect we'll continue to see that rise in the 2018 data. There is a lot of variability state to state. So this is the US map showing the % of hospitals in each state that report that they have all 7 of the core elements. And as you can see, Nebraska lags the national average just a little bit. You guys are at 62%, and nationally we're at 76%. But I know that through the ASAP program, you guys are making a lot of progress. One of the reasons why I think Nebraska and some of these other kind of states in the middle region of the country lag is that you have a lot of critical access hospitals. And we know that that's the group that has struggled the most in implementing core elements. They're challenged in terms of their resources. Bed sizes are small. They don't have, access to the traditional champions for stewardship programs. They don't have infectious disease physicians and infectious disease pharmacists. So there are unique challenges that they face. We talked a little bit when I presented last year about our specific guidance. So we actually developed some specific guidance to help critical access hospitals implement the core elements. There's an entire guidance document on implementation of the core elements for small and critical access hospitals. And the good news is that the smaller hospitals, and especially critical access hospitals, are catching up really, really quickly. So if you look at this, you can see critical access hospitals, the implementation of the core elements is at 57.8%, about 58%. They've seen the biggest rise of all of the different types of hospitals. So I think they are making substantial gains in catching up and closing that gap of stewardship implementation. And that's probably a reflection both of the specific guidance that's been developed for them, but also because critical access hospitals now have an incentive to implement stewardship programs. And when you work for the government, everything's an incentive. From your perspective, it's probably a requirement, but we think of it as an incentive through the Medicare Beneficiary Quality Improvement Program, right? The MB-QIP program, which is the quality improvement program that critical access hospitals, almost all of them, participate in to access their flex grant funds. So now, if critical access hospitals want to get those flex grant funds, which are incredibly important, and they almost all do, they have to be making progress towards implementing an antibiotic stewardship program and reporting their status of stewardship implementation to CDC. So I think those have been major developments. We continue to work with the Health Resources Services Administration, HRSA, on helping critical access hospitals implement stewardship programs. The other thing that we're working on is trying to better assess how well people are doing with telling us what's going on in their hospitals with their stewardship programs. One of the issues is that people have said, well, you're collecting this data, but is it really valid? Does it really reflect what people are doing? And we think that just the numbers provide some degree of face validity, right? We were a little worried that when we first issued this thing, like, what if everybody was like, yeah, sure, we have a stewardship program, and right out of the gate, we're at 100%. Then we're pretty sure people aren't telling the truth. But what we found is that people were pretty honest, right? We had a national implementation of about 40%, which was very much in line with other national surveys that had been done. So so people weren't just checking boxes to say they had a stewardship program because they knew that was the favorable response. They were being relatively honest. The challenge we have, though, is that the survey, the NHSN survey each year, goes to the infection, whoever's the NHSN administrator at your facility. And that's almost always your infection prevention lead. So the question became is, well, would that person know all of the details of what's going on with stewardship? You know, in the instructions, we say in the survey, you know, please get help from your stewardship program when you're filling out the survey, but, you know, we can't require that, and we don't know how often that happens. So the question then is, well, what would the survey results look like if you actually sent the survey to the stewardship program, to the stewardship lead? So we actually were able to do that. So we worked with Vizient, which is, you know, this very large group purchasing organization. They have a fairly large and active stewardship listserv. And so what they were willing to do, the Vizient does an annual survey of their members on antibiotic stewardship. So what Vizient was willing to do was replicate all of our NHSN stewardship questions in their survey. Their survey does go directly to the antibiotic stewardship lead. So for about 189 hospitals in the country, we had the same set of questions, one set filled out by whoever received the NHSN survey, and one set that was filled out by the designated stewardship lead who gets the Vizient survey. And so we were able to compare. And what was somewhat discouraging those results was that the people who filled out the Vizient survey, only just over half of them indicated that they had helped fill out the NHSN survey. So that's not ideal. That suggests that about half the time, there's not the connection being made between the NHSN administrator, the infection prevention program probably, and the lead of the stewardship program in order to get that survey filled out. Now, there may be some small differences. There may be somebody else in the stewardship program who helped with the NHSN survey, but that number was not ideal, and we need to do more to try to get that number up. The good news is that if you look at the percent of hospitals that reported all 7 elements, it was pretty much the same whether the infection prevention lead filled it out or the stewardship lead filled it out, right? So it was 55% in the NHSN survey and 58% in the Vizient survey. So that gives us at least some degree of assurance that we have a relatively fair capture of the implementation of the stewardship programs, even though not all the time is the stewardship program being engaged in filling out the survey. So what I would say is those of you who are infection preventionists in the room who are responsible for filling out the survey, please make sure that you're connecting with your stewardship program. My guess is that if you're sitting in this room, that's already old news for you. You're probably already doing it. And if you are a stewardship program, and this is news to you, if you've never heard of the NHSN survey, when you go back to your hospital, find out who your NHSN administrator is, who is filling out that survey, and make sure that they know who you are so that next year you can help fill out the NHSN survey. We also are trying to use the NHSN survey to do a better assessment of hospital stewardship programs. And we revised the survey questions this year in order to try and go a little bit deeper, to gain a deeper knowledge of stewardship programs in the United States. You know, most hospitals now have implemented the core elements. They told us, yes, we're doing the basics. So we think that presents an opportunity for us to go a little deeper. We would love to learn a little more about the specific actions and practices that hospitals are implementing, what's working, what's not working. Ideally, we'd love to know things like what is effective, what are the effective things that stewardship programs are doing. So we revised these questions for the 2019 survey, and we're looking to see is can we begin to use the survey data and pair that survey data with things like rates of antibiotic use to look at are there actions and structures that maybe are associated with lower rates of use, with lower rates of C. diff, with lower rates of antibiotic resistance. And if we can begin to draw some of those associations, we might be able to say, look, yes, we know we have 7 elements and a whole bunch of actions, but you know, it's this 1 or 2 that really seem to be associated with more impact when it comes to the outcomes of a stewardship program. What are the types of things that we added? So we talked to a whole bunch of stewardship experts and a variety of people to try to say, well, you know, if you were doing the survey, what would you want to know to help you understand if a stewardship program had what it needed in order to do its job and was actually doing the right things? And these are the types of things they said. They wanted to know more details. What type of support is being provided by leadership? Who is on the stewardship committee? They wanted more details on the program. Is stewardship in a job description for somebody? It was very interesting. They wanted to know both ask questions about how much time is allocated for people to do stewardship and how much time they spend. They wanted us to try to ascertain if there's a disconnect. And, you know, for example, yes, stewardship is 10% of my job description, but I actually spend 25% of my time doing it. They wanted to know details on prior authorization and post-prescription review, specifically which drugs people were doing, pharmacy nursing engagement, who leadership reports to, and then some questions on the use of telestewardship and decision support. So those are the questions that all of you, those of you who helped fill out the survey would have seen, and so now we'll have some answers to that starting in 2019, and we can begin to go a little bit deeper with the stewardship survey. I want to turn and talk now about antibiotic use reporting into CDC. So we have a part of our focus is measuring the implementation of stewardship programs. Another part of our focus is measuring actual antibiotic use. And of course, we do that through the National Healthcare Safety Network antibiotic use option. This option took a very long time to get off the ground. This was a new part of NHSN. It was the first fully electronic part of NHSN. You cannot do manual entry into the antibiotic use option, so there were technological hurdles that had to be overcome. And as you can see, we launched it in 2012, and I had to spend a lot of years giving this talk with a graph that was inching up incredibly, so it was really uncomfortable. It's like, yeah, we have 102 hospitals reporting, and the next year's 109 hospitals. Fortunately, that situation has changed dramatically. I think we finally reached that Malcolm Gladwell tipping point with this. So as of February, there were over 1,100 hospitals reporting, and I did get an email yesterday that I think that number now is over 1,300 hospitals that are reporting antibiotic use data into CDC's National Healthcare Safety Network antibiotic use option, and it's growing fairly quickly now. You can see the demographics. They've come from 49 states as well as DC. Average bedside is about 200 beds, so they tend to be slightly larger hospitals. We do have, though, a good collection and growing collection of critical access hospitals. Our smallest reporter is a 3-bed hospital, and our largest has 1,455 beds, and most of them are teaching hospitals, and of those about half are major teaching hospitals. They have some sort of a medical school affiliation. This is the graph showing the percent of hospitals in each state that are reporting into the antibiotic use option. And I think this graph has been growing, and it's encouraging to see now that we do have some fair degree of coverage around the country, including some states that are, you know, moving up into the 30–40% range of hospitals that are reporting. Again, Nebraska, smaller numbers of hospitals, and so I know that's something, again, that the ASAP is working on to get more hospitals in Nebraska enrolled in AU and reporting that data. Again, I think a reflection of the smaller hospitals who have more challenges with reporting. So the centerpiece of the antibiotic use option is the risk-adjusted benchmark measure of antibiotic use, right? That's why this module was created, because experts in antibiotic stewardship said the most useful thing that you could provide to us is some way for us to compare our antibiotic use to other people. Because right now my problem is I think I use a lot of antibiotics, but I have no way of knowing. And of course, when I go talk to my providers, they'll say, yeah, you know, we're probably about average. There's nothing to worry about here. So I need some evidence to know, am I low, am I high? And so that's what this ratio attempts to do. Now that we have so many hospitals that are reporting this data in, we've been working on revising this ratio and working to validate the data that's in the NHSN antibiotic use option. So the standardized antimicrobial administration ratio expresses observed to predicted antibiotic use. It's very similar to the standardized infection ratio for those of you who are used to that measure. And we predict antibiotic use based on logistic regression models, so models that will take a bunch of characteristics of the facilities that are reporting and produce predicted rates of antibiotic use, and then we can compare how much antibiotics, the actual rate of use, compared to the predicted rate of use. This measure was endorsed by the National Quality Forum in 2016 for quality improvement purposes only. And in talking to experts on stewardship, they said, we need a measure that's very different from the standardized infection ratio. They said, for that ratio, yeah, it's fine for you to give us a ratio that measures infections overall at our hospital. They said, for antibiotic use, a single hospital-wide measure is totally useless to us, because what I need is a measure that helps me understand which agents I'm using too much of and where in the hospital I'm using too much of them. So they said, we need these ratios for many different groups of antibiotics. We need them for adult versus pediatric locations. We need them for ICU and non-ICU locations. So it ends up being a large number of measures at a pretty granular level, but this is the kind of the level of detail that people wanted in order for these measures to be actionable. We first launched this measure in 2017. To be honest, we didn't have much data when we did the initial modeling for these ratios, but we felt like we needed to start and we needed to put something out there. So in 2017, we did the modeling based on the 77 hospitals who at the time were reporting data to CDC's AU option, and we had to combine adult and pediatric locations and model them together because we had so few pediatric locations. That's changed a lot. So we've redone these models now, and we use the data from 2017. So now we were able to model this using data from about 450 acute care hospitals for adults, over 2,000 locations, and we actually were able to model pediatrics separately because we now have 109 pediatric hospitals that are reporting data from 170 different pediatric locations. So because we had a larger sample size, we could do some things that were not possible in 2014, right? So we could add some new location types. When we launched the ratios, we could only model general medical and medical surgical locations, and we were able to add some more. We modeled adult and pediatric separately, and the models now are much more precise because the data going into those models is so much more significant. So we added 2 new locations on the adult side, so you can now get risk-adjusted benchmark SAR ratios for step-down units and oncology units. We picked those 2 because those are the 2 that everybody said were the most important for them. That's what people wanted. We added a ratio for antifungal agents, primarily for Candida, so it has azoles and echinocandins. Again, this was a request. People wanted this. We also added a ratio for agents that pose the highest risk for Clostridium difficile. So quinolones and clindamycin and third-generation cephalosporins are in this, and we did this because a lot of people said that a major focus of our stewardship program is addressing Clostridium difficile. So we would really like to have a ratio that shows us these agents that create the highest risks for C. diff, because those are the agents that we're focused on in our stewardship efforts. We added a single agent ratio for pediatrics. Pediatrician says, azithromycin, we use so much of it, it's so important for us. We want a ratio that only looks at azithromycin, so we added that. And finally, we added something, it's not a risk-adjusted ratio, but it's a rate distribution, because there are a number of agents now that are not used very much, things like colistin and some of the new CRE drugs. They're used very little. They're used so little that we can't really produce a ratio, a benchmarking ratio, but we do have a rate distribution. So if you are using these drugs, you can at least see, compared to other hospitals, on a rate basis, days of therapy per 1,000 patient days, how much of these agents are you using. These are just the categories. I put these in the handout so that you have them to see all of the different categories that are available. You'll see that we have done some renaming too, right? We used to have a category called agents primarily used for surgical prophylaxis. We've renamed that to be narrow-spectrum beta-lactam agents. Otherwise, most of these categories are the ones you'll recognize from the previous release of the option. But these are the categories that the stewards directed us to, right? They said these are the buckets that we think of when we think of how we might assess, intervene, and improve antibiotic use. And again, this just summarizes, like I said, all of the different locations for which you can produce these ratios. And so these are now all embedded within the NHSN application. And so if you're reporting data, you can get all of these different ratios. There's about 25 different adult ratios that you can produce and 17 different pediatric ratios that you can produce. So I'll leave the measurement piece and turn to talk about the meat of stewardship, right? Because the whole goal of all of this measurement infrastructure, the reason we want core elements, the reason we want to measure antibiotic use is ultimately to affect change. It's to improve use. All of this is intended to inform action and interventions in stewardship. We know that just having a bunch of core elements in place isn't going to improve antibiotic use. It's the specific actions that those core elements support that are actually going to improve use. And I think there's a lot that we can learn from kind of social and behavioral theory about ways that we can improve antibiotic use. And this is a really interesting book. It's a quick read for any of you who are interested in this kind of thing. I love this kind of stuff. But it's by the Heath brothers, and it's called Switch. It's how to make change. And this is not about healthcare. This is just generally how you make change. So they have examples from all sorts of different sectors. But they say that you have to think about any process as a rider on an elephant. And it doesn't matter if it's antibiotic stewardship or losing weight or getting your children to pick up their clothes off the floor and put them in the laundry basket. You have to think of it as a rider on an elephant. And that means there are only three things. You have only three options to make an improvement in any practice that exists. You can direct the rider, you can motivate the elephant, or you can shape the path. And that is it. So you have to think of every intervention and everything you might want to do as falling into one of those buckets. And ideally, you want to do things that fall into each of those buckets. So what do they mean by that? So first of all, they say one way to direct the rider is to follow the bright spots. Show the rider the things, the direction that you want them to go. So we've been trying to do that. One of the things that we know we can do is we can talk to programs that are really effective, right? So we now have rates of antibiotic prescribing. And so what we did a couple of years ago is we looked at the hospitals that had the very lowest rates of antibiotic prescribing that were reporting data into CDC. And what was interesting is when we looked at that list, a lot of it was folks that we already knew, right? There were people who were working with us, very well-known stewardship experts. But we called them up and we said, we would love to chat with you to learn why your rates of prescribing are so much lower than everybody else's. So there are two things we learned from that. One is that the lowest prescribing hospitals were significantly more likely to have all of the core elements in place. So it did suggest that if you had the foundation of the core elements, you were more likely to have lower rates of prescribing. The other thing that every one of them said is that they did prior authorization and or post-prescription review. Those were foundational intervention actions that all of these really effective stewardship programs had implemented. That's not terribly surprising given the fact that those are the two most evidence-based stewardship interventions, but it was interesting to see that all of these programs had that. And we talked to hospitals in various bedside strata. So one of the groups we talked to were critical access hospitals. And what was important to see is that all of them implement this practice differently, but they all had these practices implemented in one form or another. The other thing we have to do is motivate the elephant. And I think we all know, and you know this better than I do from your experience with talking to providers, nobody cares about antibiotic resistance except for probably the people sitting in this room, right? It's not something that providers think about on a daily basis. And I think that's fair. When I am seeing patients, antibiotic resistance and the future development of resistance is not front and center in my mind when I'm trying to think about what's the right antibiotic to give this patient right in front of me at that moment. What is much more on my mind is, does this person have a risk of C. diff? Am I going to do something bad if I give this patient an antibiotic that they don't need? And so those are the types of things that increasingly we need to emphasize. We need people to understand that there are near-term harms that you can inflict if you give people antibiotics that they don't need, right? So Clostridium difficile being a great example in the hospital setting. In the outpatient setting, that's adverse drug reactions, right? We know every year that there are 200,000 emergency department visits for adverse drug reactions caused by antibiotics. So if there are 200,000 people who go to the emergency room with an adverse drug reaction from an antibiotic, can you imagine how many people there are out there who have pretty bad reactions, but maybe call their provider, but they don't end up in an emergency department? So if you think about the fact that a third of all outpatient prescriptions are completely unnecessary, this is thousands, tens of thousands of avoidable emergency department admissions. Another area that I think is growing in awareness of people is this issue of microbiome disruption. We used to think of this as, who's going to understand this? No one's going to be into this. Now, increasingly, patients are the ones who are bringing this stuff to our attention and saying, I've read about, I'm worried about my microbiome. As kombucha sales go through the roof, people are much more worried and concerned about their microbiome and more worried about the antibiotics that you're going to give them that's going to mess up all their kombucha work. That's important for people, and I think it's important for us to take advantage of that and help people understand, hey, if I give you an antibiotic that you don't need, I am doing things to your gut microbiome that, frankly, I don't even understand, but that likely are going to have serious complications for you down the road, including increasing the risk of sepsis. And little things like specific interventions like asthma exacerbations. It's a great paper from JAMA Internal Medicine. Patients who got antibiotics for asthma exacerbation, they had longer lengths of stay than patients who did not, and they did know better. So these are I think, specific things that we can tell providers that I think are much more motivating them, telling them, improve the use of antibiotics to save them for a future generation. That is important, but I think these are much more motivating. The other thing that we can do is really work to engage providers in developing stewardship interventions, right? This is called the IKEA effect, and I read about this. I don't get this because when I buy something from IKEA, I actually am one of the people, I pay somebody else to put it together because I don't understand how to do it. But apparently, there's a universe of people out there who are so good at doing this that they actually like the product more because they put it together themselves. So this was a group of investigators that said, let's not design the stewardship interventions. Let's go find the people who are the worst prescribers and let's get them to design an intervention to improve antibiotic use. So this has been done in some hospitals in Europe and the United States. It's been very effective. And they said it's got these added benefits that the stewardship intervention becomes a real partnership because the stewardship program is saying, look, you tell us what data you want us to pull for you, tell us how you want us to monitor this, but you come up with the intervention. It's a real partnership. And the stewardship program says, this takes the burden off of us for dealing with the problem providers, right? Because we're not in charge of the intervention anymore. So when that hospitalist is misprescribing therapy for community-acquired pneumonia, I don't interact with them anymore. I send them to the hospitalist who's the lead of the program. So this has been also very effective in kind of motivating the elephant. Then we can shape the path, right? We can find ways to put new ideas into practice. Now, there are two approaches that you can take to this. There's an old school approach that's summarized by Max Planck. And Max Planck actually said that a scientific truth does not triumph by convincing its opponents and making them see the light, but rather because its opponents eventually die and a new generation grows up that is familiar with it. Now, I do not think that that is the optimal approach to implementing antibiotic stewardship in the United States. Unfortunately, there's new behavioral theory that suggests there are better ways, and this is this great book by Thaler and Sunstein, Nobel laureate, who says, you can nudge practices into existence. You can find ways to just gradually guide people, and they even use an elephant on the cover to help move things along. So the core elements, I think, have been a great example of this. There have been some good nudges of the core elements, right? It's been mentioned in the National Action Plan, the strategy to prevent antibiotic resistance. It was was the focus of a White House forum on antibiotic stewardship. So these are really good nudges, right? All of these were things that said, hey, look, these core elements are good, they're important, you should implement them, and those were very helpful. And then, of course, there's nudges and then there's shoves. And so we've now moved into kind of the shove arena with the stewardship core elements, because in 2016, CMS proposed making the stewardship core elements a requirement through the conditions of participation. The Joint Commission issued an accreditation standard for stewardship programs and the core elements in all of their hospitals. Critical access hospitals, as I mentioned, made it part of the MB-QUIT program, and just recently DNVGL, which is the other major hospital accreditation organization, has issued a standard for stewardship programs. So these aren't so much nudges, because these are requirements, right? You have to have a stewardship program under these constructs. This is something that we've been asking for a really long time, right? There have been a whole bunch of policy statements from various organizations, SHEA, IDSA, PID, saying, stewardship programs need to be a requirement for acute care hospitals. And we are there now. We have stewardship requirements for most acute care hospitals in the United States. So the question that people ask me, is that good or bad? And the answer is absolutely, right? It's both. So requirements for hospitals do good and bad things. It definitely gets you resources that you need for implementation. If you're a have-to-have, you're going to beat out a nice-to-have every day and twice on Sunday. And it creates an environment where things are more likely to succeed because they have to work. You have a required program in place. There are, of course, unintended consequences and frank downsides to doing this, right? It's an unfunded mandate. No one's getting extra money to implement your stewardship program. People talk about, it's going to lead to box checking. People are just going to check whatever box is necessary to say we have a stewardship program, but we're not really going to do anything. And then people have said, this is going to stifle innovation. Nobody's going to innovate in stewardship because they're only going to be focused on regulatory requirements. I will say, though, that I, from, of course, my perspective, have a slightly different perspective on regulation. And I think you can go into history and find examples where regulations don't stifle innovation, but actually can spur innovation. And this is a great example of that. Comes not from healthcare, but from the environmental sector. So in the 1970s, air pollution in the United States was reaching epidemic proportions, serious health problems with air pollution. Cars were the biggest contributor. So in the 1970s, the EPA actually issued regulations to reduce car emission. The problem is that the technology to meet the requirements that they put in place didn't exist. There was utterly no way, it was impossible to achieve the air pollution standards that they issued at the time that they issued it. And they said, well, who cares? You guys are smart auto engineers, you'll figure something out. So the auto industry, they didn't like that very much. There was a Chrysler engineer who testified for the U.S. Senate. This is a great transcript. And he actually said, he's like, if you support this, this will be the end of the family station wagon and the large sedan. That's it. You will no longer have these. So any of you who drove here today will know that that didn't come true, right? Cars have only gotten bigger. What happened? So car companies figured it out, right? They created all this new technology to reduce car emissions while increasing the size of the cars. So now in the year 2019, a car emits about 1/500th of what a car in the 1970s did because of new technology. And we're seeing that in stewardship, right? So if you tell every hospital in America that they have to have a stewardship program, they're going to figure out creative ways to implement that. And one of them is this idea of tele-stewardship. It's remote access to stewardship expertise. A hospital that maybe doesn't have an infectious disease person on site or even have access to it, there are a number of these programs that are saying, well, we do, and we can help you do that. So these are examples from Intermountain Healthcare in Washington, states that have a fair number of critical access hospitals. Below is the Duke network, where they're doing all of this support. So centralized support and expertise connected with a hub and spoke model to other stewardship programs. So we're seeing that kind of innovation. But we know that standards reflect their enforcement, right? So if you enforce a standard in a way where you walk in with a clipboard and you tell people, I got to check these 6 boxes or 7 boxes, that's what people are going to do. They're just going to do that. But if you enforce it in a way that kind of drives people to what good practices are, and you revise those standards to implement best practices, you can have a standard that really is a living, breathing, dynamic standard that moves practices forward. And the Joint Commission has been really aggressive in its partnership to try and do that. When they issued this standard, they said, we will issue this standard, but we want to work with you, CDC, and the practice community to really understand how to make this standard effective. And so one of the things they've done is actually been open to removing parts of the standard that were not correct and not good, right? So initially, many of you who are Joint Commission hospitals will know that one of the original requirements was that you had to generate a list of every patient being discharged from the hospital in the emergency room on antibiotics. And people said, well, that's crazy. Our hospital stewardship program doesn't look at discharge prescriptions from the ED. Why would we need to measure that? So they eliminated that requirement. The other thing they've done is they're working with a number of different groups. So they've Joint Commission, the CDC, the National Quality Forum, the American Hospital Association, the Pew Charitable Trusts are all working together, and we convened this meeting last year called Leading Practices in Antimicrobial Stewardship. And this was a meeting where we brought together a whole bunch of experts in stewardship, and we asked them these three questions. What policies and practices have been most important for your success? What measures do you use to assess the success of your program? And have you done anything that you think was novel that has worked well for you, right? So these are the types of things the Joint Commission said, if we can understand these types of things, we can put that into the survey process. So what people said, important for success, not surprising, prior authorization, post-prescription review, engagement of frontline prescribers, treatment guidelines, diagnostic stewardship, right, ways to improve diagnostic testing. The measures, what you would again expect, many people using antibiotic use measures, C. diff, compliance with guidelines, and there were one or two places that said we have begun experimenting with provider-level feedback in the hospital setting and have had some initial early success with that. So there's more to come on this. What we are very interested in is working with the Joint Commission to try to figure out what does a surveyor need to look at? How can we help a surveyor who, frankly, doesn't know that much about stewardship, right? These are surveyors who are assessing the stewardship program, the infection control program, the diabetes program, the width of the hallways, the fire code, the temperature of the refrigerators, right? They have a broad swath of things that they're looking at. So how do we help them assess a stewardship program in a meaningful way and direct the leaders in that hospital to stewardship practices and structures that would be most effective? So we're continuing to work with the Joint Commission on that. Just a final slide on some of the other work that we're supporting in hospital stewardship. There's a lot that's going on. We are working a lot with that SAR ratio, trying to understand how best to risk adjust that to make it most actionable and meaningful. We're looking at stewardship interventions at transitions of care, especially at discharge. We're funding a pilot project where people are really focusing on improving stewardship at discharge. And then we are doing some of these behavioral theory studies, right? We're doing one where this is an opt-out protocol where they're patients who are started on a sepsis pathway. If they don't meet criteria for sepsis, their antibiotics are going to be continued unless the provider actively says, no, I discontinued, unless the provider says, I'm opting out and I want to continue the antibiotics in this patient. This is based on this idea that most of the time there's a lot of inertia that goes into place, and if you can put something in that will disrupt that inertia, you can improve practices. We're also working to try to engage other groups in hospital stewardship programs, in particular pharmacists and nurses. Nurses have been a big focus for us because historically this was a huge gap in our stewardship implementation, right? Historically, we have not engaged bedside nurses in stewardship efforts. The rationale being, well, they don't prescribe antibiotics, so how could they help improve antibiotic use? That sounds ridiculous now because we know that nurses don't put in central lines, but they've been central to efforts to reduce central line associated bloodstream infections. So we know that nurses are the ones who administer every dose of antibiotics. They provide so much of the patient and family education. So we think there must be really important roles that nurses can play. They also collect a lot of the cultures. So we're working with Johns Hopkins on a project to try to engage nurses in stewardship. It's focused on these areas: collection of urine and respiratory cultures, and assessment of penicillin allergy, because these are roles that nurses have said were comfortable for them in areas where they thought they could help improve antibiotic use. And finally, we've been working with general pharmacists, so not ID-trained pharmacists, but general clinical specialist pharmacists, on ways that they can engage more in antibiotic stewardship. So we've worked with the Association of Health System Pharmacists on these posters, the 5 ways pharmacists can improve antibiotic prescribing, and we have a number of these posters, and these should be available on our website soon as a way to try to engage more pharmacists in efforts to improve antibiotic use. I'm going to close out by saying a couple of words about what we're doing in the outpatient and nursing home settings. First, in the outpatient setting, a big focus for us here is in prescribing in urgent care clinics. Urgent care clinics, I imagine that this is the case here in Nebraska. It's the case nationally. This is the fastest growing sector of healthcare delivery, right? These are these clinics that you see popping up all over the place. And if you look at antibiotic prescribing, this is inappropriate rates of prescribing by different practice settings. So this is looking at the percent of unnecessary prescriptions for acute respiratory illnesses, right? So these are prescriptions where the reason for encounter is something like viral upper respiratory tract infection, but an antibiotic is given anyway. In urgent care centers, 46% of prescriptions for acute respiratory tract infections are inappropriate. And this is a challenging setting because, that we've talked with the people who work in this industry and say, we're a slightly different model from other healthcare delivery systems because we are a real service industry. This guy, was one of these guys telling us, we're on Yelp. Right? So our reviews, our referrals come from Yelp. And we get bad Yelps from people who come to us for a Z-Pack and we don't give it to them. And that is a problem for our business model because this guy said, from the door of my urgent care clinic, I can see 2 other urgent care clinics. So if I'm not giving the antibiotics, I bet you those guys are. So this is a challenging setting, but nonetheless, it's a problem. And they're engaging with us to try and see if there are ways that we can solve it. We know that there's a key need to focus on these respiratory conditions. These are the top reasons why antibiotics are prescribed in outpatient settings. They account for about 30% of all antibiotic prescriptions in outpatient settings. And we know that if you intervene, you can drop prescribing dramatically. So we did a project with a group of VA clinics where they implemented some interventions to reduce unnecessary prescribing for upper respiratory tract infections, and we're able to reduce it by 60%. So you can make huge inroads here with some fairly simple interventions. We're also focused on trying to reduce fluoroquinolone prescribing in the outpatient setting, especially for older adults. Fluoroquinolones still account for 22% of all antibiotics prescribed to patients over the age of 65 in outpatient settings. And all of you have seen all of these warnings from the FDA. These are toxic drugs. There are a lot of complications to quinolone use, and the FDA has said, boy, these should be used really, really sparingly in the outpatient setting. Lots of risks: C. diff, tendon rupture, aortic dissection, alterations in blood glucose level. So these are drugs that we really need to seriously consider the risk-benefit ratio before we prescribe. We're also working to try and figure out if there are ways that we can play into what's going on with opioid prescribing. So on the bottom of this graph are 2 maps. One are rates of opioid prescribing in the United States, and the other is rates of antibiotic prescribing in the United States. And I don't even know if they're labeled because it doesn't really make any difference because they're the same, right? States that have high rates of opioid prescribing also have high rates of antibiotic use prescribing. So there seems to be some sort of an overlap of over-prescribing that goes on in these communities. So the question is, well, what is driving that? And are there common factors that we might be able to tap into? Are there overuse issues, educational issues that we could resolve that might help reduce both opioid prescribing and antibiotic overuse? So we're working with our opioid group to try to address this problem. This is awesome. Someone sent me a picture of this bottle. This is a bottle of amoxicillin that says "take as needed for pain." In the nursing home side, we're really in the data gathering stage. We're working with a number of vendors who do the antibiotic prescribing for nursing homes to try to get better data on what's used in nursing homes, and more importantly, what antibiotics are being used for in nursing homes. But we are engaged in a very large quality improvement project with the quality improvement networks and organizations. There are about 3,000 nursing homes in the United States that are enrolled in this quality improvement effort to try and combat Clostridium difficile, and of course stewardship is a central part of that intervention.